Bismillahirrahmanirrahim. Assalamu alaikum. Dr. Rizwan here. In our last lecture, we have discussed regarding the alpha 1 globulins and their clinical importance. And those include the alpha 1 antitrypsin, alpha fetoprotein, and orosomucoids. Today, we will start with alpha 2 globulins and beta globulins. The alpha 2 globulins include haptoglobulins, ceruloplasmin, and alpha 2 macroglobulins. And the beta globulins, these include the transferrin, C reactive protein, hemopexin, and beta lipoproteins. Now, starting with the alpha 2 globulins, the haptoglobulins, it is a plasma protein which is primarily synthesized by the hepatocytes. It exerts a broad range of anti-inflammatory activities and acts indirectly as a bacteriostatic agent and an antioxidant by virtue of its ability to bind with the free hemoglobin and to facilitate its immediate clearance by the macrophages. It is a plasma glycoproteins that binds with the extracorpuscular hemoglobin in a tight noncovalent complex which is known as hemoglobin-haptoglobin complex. The amount of haptoglobulin in human plasma ranges from 40 milligram to 180 milligram of hemoglobin binding capacity per deciliter. The functions of haptoglobin is to prevent loss of free hemoglobin in the kidneys. It conserves the valuable iron which is present in the hemoglobin, which would otherwise be lost from the body. The molecular mass of hemoglobin is approximately 65 kilodaltons, and this complex hemoglobin haptoglobin complex has a molecular mass of approximately 155 kilodaltons. The free hemoglobin passes through the glomerulus of the kidneys and enter the tubules and tend to precipitate therein, as can happen after a massive incompatible blood transfusions when the capacity of haptoglobin to bind hemoglobin is grossly exceeded. However, the hemoglobin haptoglobin complex is too large to pass through the glomerulus of the kidneys. Thus, haptoglobin help to conserve the iron which is present. Now, in this diagram, it shows that haptoglobulin protects the kidneys from the damage by extracorpuscular hemoglobins. The sentient or the damaged erythrocytes, these are the phagocytosed by the macrophages of the reticuloendothelial system which are present in the spleen and the livers. The sentient erythrocytes are phagocytosed by the macrophages, and the hemoglobin is degraded and iron is released from the heme by the action of an enzyme which is known as heme oxygenase. The pyrrosines is then transported out of the macrophages via ferroproteins, and in the plasma it is oxidized to ferric form by ceruloplasmin before binding to a transferrin which is iron binding protein, and it circulates the blood tightly bound with these transferrins. The iron which is released from the macrophages in this way, this is about the 25 milligram per deciliter. It is recycled and forms a major source of iron in the body in comparison to the intestinal iron absorption, which contributes only 1 to 2 milligram of the body's daily requirement of the iron. So, it acts as a scavenger for the hemoglobin which has been utilized by the recycling. The clinical significance of haptoglobulins, its concentration rises in the inflammatory conditions and the concentration decreases in hemolytic anemias. The half life of haptoglobin is approximately 5 days, and the half life of the hemoglobin haptoglobin complex is about 90 minutes. The complex being rapidly removed from the plasma by the hepatocytes. Thus, when haptoglobin is bind to hemoglobin, it is cleared from the plasma about 80 times faster than the normal procedure. The level of haptoglobin falls rapidly in hemolytic anemia. Now, the second alpha 2 globulins is the ceruloplasmin. The normal plasma concentration is approximately 30 milligram per deciliter. The enzyme activities are ferroxidase, copper oxidase and histaminase. It is synthesized in the liver in the form of apoceruloplasmin. When copper atoms gets attached, it becomes ceruloplasmin. Although it carries 90% of the copper which is present in the plasma, but it binds copper very tightly, so that copper is not readily exchangeable. And the albumin carries the rest of the 10% of plasma copper, but it binds with the metals less tightly, and as does the ceruloplasmin. The albumin thus donates its copper to the tissues more radially than ceruloplasmin, and appears to be more important than ceruloplasmin in the copper transport in the human body. The normal level of ceruloplasmin is 25 to 50 milligrams per deciliter, and the low levels of ceruloplasmin are found in Wilson disease, which is a hepatolenticular degeneration and a disease due to the abnormal metabolism of the copper. Another important disease which also appears due to the low levels of copper, that is also known as the Menkes disease, and it is a defect in incorporation of copper into a newly synthesized apoceruloplasmin to form ceruloplasmin. This basic defect is in the mutation in the genes encoding the copper binding ATPase in the cells. The amount of ceruloplasmin in the plasma, it also decreases in the liver disease, malnutrition and nephrotic syndrome. The third one, alpha 2 globulin, is alpha 2 macroglobulins. It is a major component of alpha 2 proteins. It comprises 8 to 10% of the total plasma proteins in the humans. It is a tetrameric protein with molecular weight of 725,000. It is synthesized by the hepatocytes and macrophages and inactivates all the proteases, and thus it is an important in vivo anticoagulants. It is a carrier of many growth factors, and normal serum level of alpha 2 macroglobulins are 130 to 300 milligram per deciliters. Its concentration is markedly increased in the nephrotic syndrome, since the other proteins are also lost through the urine in this condition. Now, we will discuss the beta globulins, that includes transferrin, C-reactive protein, hemopexin, complement C1q and beta lipoproteins. We will discuss it one by one. In the very first, beta globulin is the transferrins. This beta globulin of plasma is a non-heme iron containing protein. Previously, it is named as a siderophylline or acidrophylline. It is the true carrier of iron. The transferrin is a beta 1 globulin with a molecular mass of approximately 76 kilodaltons. It is a glycoprotein and is synthesized in the liver. About 20 polymorphic forms of transferrins have been found up till now. It plays a central role in the body's metabolism of iron because it transports iron in the circulation to the site where iron is required or the needed, for example, from the gut to the bone marrow and other organs. approximately 200 billions of red blood cells are catabolized per day and releasing about 25 milligrams of iron into the body, and most of which is transported by this plasma protein, that is transferrin. In this diagram, it is shown that the non-heme iron is transported into the enterocytes, and the ferric ions, they are reduced to the ferrous form by the luminal ferrireductase and the duodenal cytochrome B. The ferrous iron is transported into the enterocytes via a divalent metal transporter. It is also known as DMT1, and within the enterocytes the iron is either stored as ferritin or it is transported out of the cell by ferroprotein. In the ferrous iron, it is oxidized to its ferric form by the hephestin. The ferric iron is then bound to transferrin for the transport by the blood to the various sites in the body. So, this diagram shows the non-heme iron transport within the lumen of enterocytes. Now comes the transferrin receptors. There are the receptors which are known as TFR1 and TFR2, transferrin receptors 1 and transferrin receptors 2, which are present on the surface of many cells for transport of transferrins. It binds to these receptors and is internalized by the receptor mediated endocytosis. The acidic pH inside the lysosome, it causes the iron to dissociate from the protein. The dissociated iron, it leaves the endosome via these DMT1 receptors to enter the cytoplasm. The apotransferrin is not degraded with the lysosomes. Instead of it remains associated with its receptors and returns into the plasma membrane and dissociates from its receptor. It re-enters into the plasma and picks up more iron and again delivers the iron to needy cells. Normally, the iron bound with the transferrin turnover, it is 10 to 20 times per day. Now, in this diagram, these are the transferrin receptors which are transported by these DMT1 transporter, and the ApoTF, these are not dissociated, and the dissociated iron, this is transported and endocytosed by the presence of a clathrin coated pits into the vacuole and endosomal membrane, and then it is dissociated into its ferric form, and that is bound with the ferritin. Again, it is a transferrin cycle. This diagram also shows the receptors which are present on the surface and transport of these receptors and iron molecule within the enterocytes. The clinical significance of transferrin, it includes the concentration of the transferrin in the plasma is approximately 300 milligram per deciliter. This amount of transferrin can bind 300 grams of iron per deciliter, so that it represents the total iron binding capacity of the plasma. However, the protein is normally only 1/3 saturated with the iron. The iron deficiency anemia, it is the protein is even less saturated with the irons, whereas the conditions of the storage is excess in the body. For example, hemochromatosis, the saturation with the iron is much greater than the 1/3. The clinical significance of transferrin also includes when the levels are increased. These are seen in the iron deficiency anemia and in the last months of pregnancy, and the decreased level of are seen in the protein energy malnutrition, cirrhosis of the liver, nephrotic syndrome, trauma, acute myocardial infarction, malignancies, and muscle wasting diseases. Now coming toward the second, beta globulins, that is the C-reactive proteins. It is named so because it reacts with the C polysaccharides of the capsule of the pneumococci. The molecular weight is 115 to 140 kilodaltons, and it is synthesized in the liver and can stimulate the complement activity and macrophages. It is also an acute phase protein, and the concentration rises in the inflammatory conditions, and clinically it is important marker to predict the risk of coronary heart disease. The next beta globulin is the hemopaxin. Its molecular weight, it ranges 57,000 to 80,000, and the normal level in adults are 0.5 to 1 grams per liter. The low levels are present at birth, and it reaches adult value within first year of life. It is also synthesized in the liver, and it functions to bind heme from the breakdown of hemoglobin and the other hemoproteins. The low level found in hemolytic disorders at the birth and drug induced, and the high level these are seen in pregnancy, diabetes mellitus, malignancies, and Duchenne muscular dystrophy. So for the today's discussion, we have discussed up till now the alpha 2 globulins and beta globulins. I hope you will understand the lecture, and the remaining part we will discuss in our next lecture. Okay, Allah Hafiz.